Hey everyone, welcome back to our provider development series. We're going to continue on with our clinical reasoning lectures, and today we're going to finish up the second half of part 3, or part 3.5. So if you remember from the last session, we started talking about cognitive errors, specifically cognitive errors that are caused by biases. And today we're going to transition into how to combat them. Okay, so I've laid a ton of groundwork the past 4 or 5 sessions. There's enough groundwork to fill a whole lake. It's finally now time to start getting into some practical ways that we can actually improve our clinical reasoning skills. Okay, but first, we've got one more review slide. Okay, so we talked about this a lot in our second video, but it's important to review this really quick because it's going to be really relevant today. So remember, there are 2 types of thinking. There's 2 different ways that we providers think about problems. Okay, so we have type 1 thinking. Okay, this is our non-analytical reasoning. It's emotional, it's quick, it's often done subconsciously. We use things like pattern recognition, and as we gain more experience, this is the predominant type of thinking that we do with clinical problems. Our type 2 thinking, on the other hand, is slow, deliberate, methodical, logical, effortful, analytical reasoning. Okay, it requires extra attention and self-control. Okay, it's important to remind ourselves of these 2 different types of thinking because one of the main ways that we can combat all the biases that we've talked about is by forcing a cognitive slowdown, meaning that we have to force ourselves to transition from type 1 thinking to type 2 thinking. Okay, and as we'll talk about, some of the strategies that you can use to improve your clinical reasoning skills often will be felt to be time-consuming and will require some extra effort. Okay? Now, this is especially true for our more experienced clinicians. As I mentioned, for our type 1 thinking, that's going to be our predominant type of thinking that the seasoned clinicians will use when they're approaching problems. Okay? And so it's going to feel like you're taking extra effort to transition back into this type 2 thinking. And I recognize that forcing yourself to perpetually slow down, can cause some undue cognitive and emotional stress. Really, for a lot of times, for minimal gains, especially for our really astute clinicians. But don't let good be the enemy of great. Okay. So with all that in mind, I think the trick to gaining diagnostic accuracy or diagnostic mastery is to figure out when it's most important to proceed cautiously. Okay? In other words, you only should be slowing down to your type 2 thinking when it's necessary. Okay? So how do you do that? How do you determine when you should do that? Okay? So I find that asking questions like these can help you determine if it's necessary to even do it. Okay? So kind of steal a term from the surgical world, I would call this a diagnostic timeout. Okay? So let's make sure you're on the right track before proceeding. Let's make sure that we're actually supposed to amputate the left leg and not the right leg, right? So the questions that I think are helpful to ask are things like, what else could this be? What finding doesn't fit with my diagnosis? Could there be multiple processes ongoing at the same time? How does this patient make you feel? When I'm on the resident service, I tell this to the residents a lot. This patient just doesn't feel right, but I often struggle to articulate why that's so. But when you're feeling that feeling, maybe we should slow down and transition back to type 2 thinking. Okay. And then another question is there any other reason that I need to slow down? Okay, so let's talk about some ways that can help us improve our clinical reasoning. First of all, simply being aware that these biases exist and being familiar with the dual cognitive model way of thinking that we talked about, and understanding that we sometimes do need to slow down based on the answers to the aforementioned questions. Just being aware of all that can improve performance. Okay. Now, of course, that's not enough. Just listening to these lectures aren't enough. But what this awareness does, though, is that it kind of primes the cerebral pump, so to speak, allowing for incorporation of other cognitive strategies which have been shown to reduce diagnostic error. So greater awareness of one's thinking, along with some of the other techniques that we'll talk about, can really seed the development of better diagnostic habits. Okay? Also, being aware of these types of issues can significantly reduce the personal stigma of cognitive errors. Okay, so when you make a mistake, you understand why and you can process it better. Okay, let's talk about our first real technique, and that is metacognition. Now, as the name implies, metacognition is the act of thinking about one's thinking. And this technique has the potential to mitigate diagnostic error by allowing the clinician to develop insight and awareness into their own thought patterns. And it can also kind of provide a double check to potentially biased thinking. Okay? Metacognition is also useful in reflective exercises, okay, both in successful and unsuccessful diagnosis. So I want to talk about this a little bit more. Okay, so there are actually two techniques that fall under the metacognition strategy. The first is what we call forced cognitive strategy, or the other name is the two-pass diagnostic approach. And this is where you essentially initially form a gut reaction for a diagnosis, followed by a more analytical, slow second pass. Okay, so this really works great for all types of clinical scenarios, but a great example is how I look at an EKG or a chest x-ray. Okay, so you need to generate an immediate feel for what the diagnosis might be, on the EKG, but then you need to take a step back and systematically go through it and look at the rate, rhythm, the access, etc. Okay? The same for a chest x-ray. Get a gut feel for it, say, yeah, it looks like he's got some pulmonary edema, but then systematically go through your A, B, C, D, E mnemonic to ensure that you're not missing something. Okay? Now, a quick caveat to gut reactions that you need to be aware of, that the accuracy of gut reactions is directly proportional to how much experience and expertise you have. Okay, so if you're dealing with a case that you don't have the prerequisite knowledge that's required to master it, your gut reaction is really worthless. Okay? The second metacognition technique is what we call structured reflection. Okay, so with this technique, you take the top 4 or 5 diagnoses that may be under differential, and you essentially make 2 mental columns. Okay, so you'll start with your most likely diagnosis, and then in one mental column, you'll list all the facets of the case that support this working or most likely diagnosis. And then in the other mental column, you list all the facets of the case that argue against it. Okay, so then you repeat this process for the next most likely diagnosis and the next most likely diagnosis. And then you can move forward with the diagnostic plan and arrive at what you think your conclusion should be. This framework is also helpful to incorporate new clinical data as it comes available. Okay, famously, Ben Franklin used this type of approach when making any decisions, even mundane daily decisions like what he'd have for breakfast. Okay, so it sounds silly, and it definitely will slow you down, but the key is, as I mentioned, is knowing when to slow down and when to do this. You want to be accurate in your diagnosis, of course, but you also have to be efficient, right? This particular approach is especially useful when the initial presentation is nonspecific or contains discordant information, as a lot of our patients do. The take-home point, though, is that while this may feel inefficient, pushing yourself to explain why the diagnosis is likely and not just saying this is the diagnosis will make it more likely that the diagnosis is actually correct. Okay, so another way to improve our clinical reasoning skills is by fostering and improving our non-analytic reasoning. So what I'm saying is that we need to consciously work on our subconscious thinking. We need to put effort in improving our gut reaction and our clinical intuition. Okay, now this will come naturally as we gain experience, but we need to be deliberate about it, okay, because non-analytic reasoning really remains the foundation of diagnostic prowess, okay, and we're going to talk about several evidence-based strategies to accomplish this. So here are the different techniques that have some evidence behind them that help improve your clinical intuition, okay. Now these warrant some dedicated time to go through each one, and so we'll come back to these in part 4, but the message here is that you must spend time, you must spend effort on improving your non-analytic reasoning, okay? And that's going to allow you to combat biases and reduce cognitive error. All right, next thing, we have to reduce reliance on memory, Okay, that's going to enhance how we think, and I want to give you a few examples. So, making use of checklists can be really helpful. There's strong evidence that checklists reduce medical error, especially in the critically ill patient or the complex patient. Okay, other industries like the airline industry has made use of checklists, and it saved lots of lives, right? Mnemonics can also be ways to reduce reliance on memory. They're not only going to make sure that you're considering everything that's essential. You don't want to forget the pee in mud piles. You might miss a really important diagnosis, but it's going to take away some of that effortful thinking that it's going to require to reach your diagnosis. And then lastly, we just need to recognize there's some things that we shouldn't commit to memory. I've got a couple examples listed here of things that I just refuse to commit to memory because I just can't seem to remember it. When it comes to autoimmune antibodies, do I order anti-SCL70 or anti-smooth muscle antibody for this workup? I can never remember it, so I just look it up every time. Same for interpreting hepatitis B antibody results. I've got all the antibodies saved in a folder. I'll order them when I need to, and then when they come back, I'll pull out my little cheat sheet and figure out what their immune status is for Hep B. I just refuse to commit it to memory because I haven't been able to after all these years. Okay, so just look it up. All right, so the next thing that can be helpful in reducing cognitive error is recognizing and then compensating for the pitfalls of the system within which we work. Okay, so the second part, the compensating part, really is key. Okay, so this is a slide from our first session, and while the provider and the patient make up the majority of the etiologies of diagnostic error, we can't forget that the system contributes a good chunk to this too. Okay, so it's important to be mindful that the system's imperfections not only exert negative influences on individuals but also teams. Okay, I want to give you a couple of examples of what I mean by being aware and compensating. So, say you've got a boarded patient lying in the halls of the loud trauma bay downstairs in the ER. Okay, now I understand that you've got to go and see this patient. You've got to evaluate them so you can get the orders in and get them admitted. But you also need to recognize that you're really hamstrung by the environment that you're in and by the system that you're in. Okay, so when this happens to me, I try to make a mental note to maybe reconsider taking the patient's history or re-auscultating their heart and lung sounds once they get upstairs into a more quiet room, because I know that being in the ER, I'm going to miss some things. Another example is our inadequate follow-up mechanisms for pending pathology. Okay, so our post-discharge messaging system has gotten better, but for patients in whom I have a high suspicion for cancer, I'll set some de-identified reminders in my phone to follow up on it in a few days to make sure that doesn't fall through the cracks. Okay, so kind of summarizing the system, you need to be aware of the system failures, which is not always easy, but then make a dedicated effort to compensate for it. Okay, I do want to emphasize though that these compensation measures should not just fall on the shoulders of physicians and APPs. Okay, our divisions and our departments and our institution all have an obligation to compensate or remedy these errors. Okay, the least fun of these techniques, admitting mistakes. Okay, so when it comes to admitting mistakes, it has to be done on two different levels. Okay, the physician and APP level and the hospital level or the department level. As a provider, I'll be the first to admit that once I realize I've made a mistake, the first thing I try to do is justify my thinking, or I become defensive and I want to figure out or explain why I did what I did. And honestly, for most of us, when we do make a mistake, typically in that moment, maybe we made a decent decision. As we talked about in the last video, hindsight bias sometimes makes it seem a lot worse than it is. But let me suggest, instead of trying to justify your decisions, rather really try to seek why you made that decision in the moment and think about how it affected the outcome of your patient and how you could have done better. Okay, I'm not saying you need to document any of this. For legal reasons, you probably don't want to. I'm just saying, as a mental exercise, take a step back and think through that mistake. Now, how does a department admit mistakes or think about ways they can do better? I'm not talking about things like public apologies. I'm talking about things like M&M conferences or clinical improvement conferences or some of our quality initiatives, root cause analyses, accountable care teams, those sorts of things. Okay. All right. So let's stop there. This will conclude part 3. And in part 4, we'll continue discussing more ways that we can put this into practice. Okay.